Welcome to Recovery Unleashed, the podcast where we dive deep into transformation, healing, high performance, and recovery. I'm your host, Hannah Dalby. I'm the founder of Recovery Jungle, Recovery Unleashed. I'm an integral alchemist, food coach, a recovery expert, and also a retired professional Muay Thai fighter and current Jiu-Jitsu lover. In each episode, we explore what it truly takes to break free from addiction, trauma, self-sabotage, and unlocking a life truly filled with energy, success, and peace. Through my very own story of addiction recovery and raw conversations with experts, coaches, athletes, healers, we uncover the tools and mindset shifts needed to master recovery in every area of your life. This isn't just about healing, this is about unleashing your full potential. You're ready to reclaim your life, tune in, do the work, and let's rise together. Welcome back to Recovery Unleashed. Today we have Dr. Julius Torelli. He's a board-certified cardiologist who, after decades of practicing conventional medicine, began something most doctors miss: the mindset, emotion, and personal responsibility profoundly shaping health. He's the creator of Gratefully Well, a pioneer in teaching the mind-body-heart connection, and a powerful voice for the new paradigm of healthcare, one rooted in radical responsibility, self-sovereignty, gratitude, and the science of belief. This is one of those conversations that bridges science, spirituality, and self-leadership in a way that only a true embodied physician can do. If you're ready for a powerful perspective shift on health, healing, and what it means to be sovereign in your own body, this episode is for you. Welcome, Julius.
Good to see you, Hannah. It's an honor to be here.
Yeah. I'm introduced to you by Gavin, who we all love. Everyone on this podcast knows Gavin well now. So can you do a little bit of an intro to yourself and a bit of your story for me?
So I'm a cardiologist, traditionally trained cardiologist, who very early in at the end of my education, that is medical school, I saw a patient who basically was having symptoms of nausea, vomiting, and dry heaving for like 3 days. Couldn't keep anything down. Was very dehydrated. We didn't know what was going on, so we put her in the hospital and hydrated her up and did some tests, and everything came back normal after about 3 days. And so when I went to discharge her, I made a corny comment as I was sitting there filling out her discharge instructions. So I was making small talk, and I said something like, we're going to get you home so you can get some real rest, because you can't rest in the hospital because they're always bothering you. Mm-hmm. And she said, "Oh, I wish." I said, "Oh, you wish? What do you mean you wish?" She says, "I wish I could go home and get some rest." And I was like, "Oh, why can't you?" And she was like, "Well, in the last 6 weeks, my husband left me. My dog died and my house burned down."
Yeah.
And in that instant, like, my mind was flooded with thoughts, but in that instant, it was intuitively obvious to me why she was sick.
Yeah.
And that was the first thought. The second thought was, here I was, this was literally, I don't believe in coincidence. This was literally the last week of medical school. In fact, when I was discharging her, it was probably the last 2 days of medical school. And I was like, wait a minute, if this is what I think it is, I didn't learn anything about this in medical school. So then my next thought was, well, then maybe it's not a thing.
Right.
But then I said, well, if I went outside and polled like 10 lay people, non-physicians, they would all say, "Oh, no wonder she was so sick."
Yeah.
And yet if I asked 10 physicians, they would sort of be like, well, what's that have to do with anything? Not exactly, right? But something like that. And so then I was like, well, okay, then maybe I need to go I got access to a whole medical school library. I said, maybe I need to go to the library and read about this. And then I was like, well, I don't even know where to go look for this. Like, I don't even know if it's a thing. And if it's a thing, if it's not a thing, you don't treat it. If it is a thing, like, how do I treat it? And anyway, I was all confused. I didn't know. I just had confusing thoughts, and it was clear I hadn't learned anything about this, but yet it seemed, again, just obvious. And so,
how long were you at medical school for?
So medical school here is 4 years. So college is 4 years, then medical school is 4 years, and then internal medicine residency was 3 years, and then cardiology was another 3 years. And so
all that time you didn't learn anything about that?
Yeah, so that's what, 14 years. No, so then I was a busy time. I was in Tampa, Florida. I had to move to Cleveland and I did all that. But that patient stayed with me,
Yeah.
right? And then I saw that patient over and over again. Like,
Right.
what you do in your training is not outpatient stuff, it's more inpatient stuff. So it's a little, maybe the percentage is a little bit lower, but even in the inpatient world, you don't see, like, there's a lot of people come in, you don't find anything physical. But if you look at the outpatient world, especially, I would say the great majority of people who come in with symptoms, we don't find anything physical. We don't find a physical problem, right? So there's a term for that called medically unexplained symptoms. The poster childs for that would be like migraine headaches and irritable bowel are probably the two poster childs, but we have a whole
Yeah.
slew of them. That
Yeah.
doesn't matter. Cervicalgia, which is neck pain, you can't find anything. Non-cardiac chest pain, which is chest pain where the heart is normal. Palpitations, irritable bowel syndrome, fibromyalgia, where people ache all
Yeah.
over, right? Chronic fatigue syndrome. These are all symptoms that patients have. We would call them illnesses, but whatever, conditions, whatever you want to call it, that can be, debilitating, sometimes even disabling. I mean, migraines and irritable bowel can be very debilitating sort of thing. And we don't find anything, but yet, and so we don't know what to do with that. And so in Western medicine, we basically have, I always say we have a toolbox to fix things. And if you open up that toolbox, the first tray in the toolbox is like procedures, right? Surgeries and things like that. If you don't need a surgery, right? You have irritable bowel, you don't find anything, or migraine headaches, you don't have a brain tumor. If you have a brain tumor, it's a different story, but that's a very small percentage. If you don't have a brain tumor, right, then you take out that tray. The only thing left in that toolbox to fix things are pharmaceuticals. We don't have any other tools in Western medicine. That's what we do. And so doctors in general, want to help. And so it becomes a little bit of a challenge because then you start giving medicines. And so, as you've heard me say before, right, it's not unusual. Migraine headaches is a great one. The medicines in irritable bowel had been much less effective, the development of medicine. But in migraine headaches, like, we understand the pathophysiology that's going on. We understand what's causing these things, even though there's nothing physical to sort of find. And so we have developed medicines that prevent migraines. We've developed medicines to treat, for pains or treat the migraines. But then, patients with migraines are, they're miserable. And so they might end up on an antidepressant. They probably are anxious. Maybe they'll end up on a sedative for something for their anxiety. They're probably not sleeping well. So they end up something to sleep. So the next thing you know, you're on 3, 4, 5 medicines, which some of them may have side effects and things like that. And I don't even have a problem with the medicines. Like, if their medicines are working, that's fine. But the issue is that the medicines aren't doing anything to the root cause of the migraine headaches or the irritable bowel or the fibromyalgia or whatever it is, right?
So it's a big mask.
We all inherently know that there's an emotional component to this that we don't understand well, right? But inherently we know it's there because doctors will figure, oh, it's just stress. So here are these 5 medicines, none of which, do anything for your stress. I don't like to call it stress. I like to call it emotional overwhelm. But regardless, it's an emotional sort of thing. And at the very least, I think someone with migraine headache you want to give them the medicine, but in addition, they should be seeing a therapist, a counselor, a psychologist, or whatever, like every one of them.
An
but yet
integral
only very
alchemist,
small
Julius.
percentage. What's that?
An integral alchemist, Julius.
Or something that where they are dealing, someone who's going to look and help them deal with, these let's call it emotional sort of even, issues, whatever. But that tends not to happen. And so that's a long-winded introduction to who I am and what I do.
It's an amazing thing because, I talk about this all day. I have a clinic where we're solving physical pain and fibromyalgia and chronic fatigue and back injury pain and headaches with integral alchemy, with emotional work. And people might turn around and say, oh, some coach or woo-woo or whatever. But to have a physician sit in front of us here and go, no, this is it, I think can kind of move people in the direction of like, all right, because we've got this like two sides of the table, right? Is it the science over here and then the woo-woo over here? And it actually needs to come together.
Yeah, and the problem is that in our society we think of a lot of this emotional stuff as woo-woo stuff, but it's not woo-woo stuff. I mean, it can get kind of woo-woo, but I mean,
Sure
but
can.
and there's many ways to deal with emotional sort of issues. I don't think there's any, let's call it right way. I mean, I have my preferences, but I don't necessarily believe in not much in like psychoanalysis and talk therapy and going back and doing even like inner child stuff. I don't, not to say that it may help some people. It's sort of not my shtick, so to speak. But there are many ways to sort of get at that. The question is, the issue is not getting to it and doing something about it and addressing that. And again, it's hard to do that kind of work, I think, if you're having recurrent migraines and you're sick. So taking the medicines, helping the migraine in the meantime, no problem. That's a great thing to do, but do it, right? And then eventually get to work on that foundational issue so that you can get off of the medicines, because the medicines aren't curative, whereas a lot of this emotional work can be.
Yeah, and I think that's fair. It's like there's an argument that I've had before of like, our SSRIs, like, is there a point in SSRIs? Is there a point in antidepressants and anti-anxiety medication? It's like, all right, well, if you can get someone off the ledge for a moment so they can do the emotional work,
Correct.
But then get off of it. It's not like a long-term, I'll be on these for the rest of my life. It's like, get you to a stable place to do the work. Same as, even having an addiction, right? It's like, well, keep your addictive behavior for a little bit if you need to, but then do the emotional work so that you're capable to stand without it.
You got it. I think that's exactly right. And so it's, like, even for other things like, when known physical conditions like, hypertension or heart disease, I still believe all that emotional work needs to be done. But in the meantime, that emotional work takes time. Your blood pressure is high. That's not good. Take the medicine, bring it down while you're doing that emotional sort of work, and while you're doing other things too, meditation and, all that sort of stuff, and learning, because that stuff takes some time to work through, takes time to learn those techniques and things. And so while you're doing that, take the medicine with the thought of, hey, one day we can get off of this. In Western medicine, we rarely stop medicines for chronic disease. I mean, which is why the pharmaceutical companies have done so well financially, right? Because you put on the medicine, you have to buy it, take it every day, buy it every month for forever, right?
So do you think that that's part of why Western medicine isn't being taught this stuff?
Well, I like to look at it in a little sort of from a different perspective. And that is because a lot of people will say that. A lot of people will say that, like in the US, like the healthcare system is broken. Like right now, the costs are just growing astronomically. And the most common cause of personal bankruptcy in the United States is medical bills.
Wow.
Yeah, isn't that incredible? But the issue is sort of the model, right? So the model in Western healthcare is it's an illness-based, right, fee-for-service model. So in Western medicine, in the U.S. for certain, the healthcare system, hospitals, physicians, durable medical equipment, everything, they only make money when people get sick, right? And so and that's the way the system is set up. It's set up, to function that way. So when that happens, there's no incentive to keep people well. There's no incentive for prevention. There's no incentive for wellness, right? But that's the way it's set up. No one in the United States wakes up in the morning and goes, man, I'm feeling good. I'm gonna go make an appointment to see my doctor and see what I have to do to continue to feel well, to be, to prevent illness. Nobody says that, right? Even on your annual visit, we have all of our health plans, want you to have an annual visit. The annual visit isn't a wellness thing. It's to check for disease. They screen for a blood pressure. They screen for cholesterol. They screen for, breast cancer. They screen for prostate cancer. They screen for colon cancer. All of these things. I'm all for screening. I'm all for early detection. It's just not prevention. So we know very little about prevention because in the United States, there's no money in prevention. So we've got, we spend billions and billions of dollars on studies to show the effectiveness of drugs. I don't care if it's for cancer or blood pressure or cholesterol or diabetes or whatever it is. And we're hooked on these drugs, right? Because, we use the great example, right, are the GLP-1 drugs, and the Ozempics and stuff. and for weight loss, and they're like the pharmaceutical companies are laughing all the way to the bank. They are effective, right? But again, where it's like people would rather it's just easier to take a pill, than it is to sort of,
And
make
I
a
think
life.
I think that's people's mindset as well, right? Like, what is the quick fix that I can have? Because in my clinic we had a fat freeze machine, and we could freeze people's fat off. And I had to take it away from people, because it was like, even though we were sitting here doing the emotional work, they were like, yeah, but I just keep freezing it off, and I just keep freezing it off. And so it's like, take it away, and like the amount of weight loss that we've done with just emotional work, because it's like, well, how am I protecting myself? How's my cortisol is through the roof? Like there's all these weird things that happen inside. I mean, I went through it. I went through having to do, like, my abandonment wound was holding all of this weight onto me, and like in releasing it and starting this podcast and speaking my truth, and I eat whatever as much food as I want, good food, but as much as I want, and it just fell off of me. It's like, well, we don't need these things. We need to deal with all the stuff we're holding on to real tight.
Yeah. Yeah, that's a great point. I think, again, people sort of don't realize people always say, oh, you got to lose weight, you got to stop smoking. Like, people sort of know that, but no one sort of looks at it from, why are you, overeating? Why are you, smoking? Because everyone knows you shouldn't smoke, right? That's not, people say, do you tell your patients they shouldn't smoke? Not really. Like, I tell my patients things they may not know. Like, they all know that. If you say, why aren't, you need to quit smoking, that's just sort of lays a guilt trip on them. But if you say to them, why are you smoking?
Yeah.
A whole nother question, why are you overeating? Because I agree with you. Like, obesity, I think from an emotional standpoint is a form of protection, right?
Yeah.
But we don't look at it sort of that way. We look at it from a very physical sort of, component. And then, you just take the drugs because it's easier to do than to do the emotional work. Because as you know, doing the emotional work,
it's rough.
Sometimes it takes a lot of courage, and it can be like the most difficult thing to do. Yeah. It's just easier to take a pill.
Well, in some sense, because we were talking about this yesterday, like, if someone wants a quick fix, doing the emotional work is actually a quick fix. It's just really, like, it's simple and it's fast, but it's really hard.
Yeah, it's really hard. And people, again, in Western sort of societies and such, like, we underemphasize this mind-body connection, right? Like, we are so stuck in the physical, right? That 99.999% of what we think about is the physical. And certainly, all these emotional issues manifest physically, right? Because if you're having an emotional issue and you're stressed and you hold your shoulders up all the time, you're going to get a neck ache, and it probably lead to muscle tension, and probably lead to tension headaches, and maybe even migraines, right? But we don't. So it's not woo woo. You know what I mean? Right. If you're having an issue where, you get startled, right. And, you hear a noise, and then after that, like, you start thinking, like, it's at night, it's late, you hear a noise and you get startled, your heart starts racing, your palms get sweaty, your blood pressure's up if you measured it, and things like that. If you go down, and then you start thinking, oh, wait, maybe I forgot to lock the door. Maybe someone broke in. Now your blood pressure is even higher. Your heart rate's even higher, right? And your body is having the exact response it would have as if someone had broken in, even though it turns out, something just fell over and made that noise. So it's not the fact that someone broke in, it's the thought. And we don't like, and you can, and there's many examples of this, right? You can relax and picture a lemon and feel a lemon and smell the lemon and cut the lemon and bite into the lemon in your imagination, and you will salivate, right?
I'm doing it now.
Yeah. You see, and that's like, again, that's a powerful physiologic reaction to an imaginary to a thought.
Yeah.
Right? And we don't talk about that enough. We know about the placebo effect as an example. Like, that's a scientific proven thing, right? In the West, we'd like to look at that as a nuisance, right? I look at the placebo effect and I'm like, oh my God, that is unbelievable. How can we amplify that, right? So the placebo effect tends to work 15 to 30% of the time, maybe. And I'm like, how do we amplify that? Whereas, like, the pharmaceutical industry hates it because they've got to do $1 million studies to show that their $1 billion drug works better than a sugar pill, because the sugar pill works, right? And so we've got this, but it's easier to just give someone a pill than it is to try to do this emotional work, because as you know, doing this emotional work, it's not something you can do in a 10-minute visit,
Yeah. Well, I think about what you've just said there, and then I think about the sessions I run, right? And I'll put people into a specific state, like, okay, well, imagine that last time that person triggered you, and then noticing the things in their body, and their stomach tightens and their shoulders come up and their heart feels all this pain. It's like we can get those feelings in a 30-second, like, okay, just go back to that moment. And then the same thing in like, okay, well, imagine your life in 6 months and there's $1 million in the bank and you've got the body, and they're like, oh, all of these things. And then noticing, oh, there's like a fear here as well. It's like all of these things that we can do with our mind can evoke these somatic responses in our body. And how useful is that?
Yeah, I mean, again, I think it's incredible, and yet, we don't talk about it. We just treat the physical symptoms, but again, as you've seen in your work, body workers also understand this, right? Like, you do get body work done, and you will see people start crying, and they have all these emotional sort of releases because somehow emotions get stored in the body. I don't know how it works. They didn't teach me this in medical school. But any body worker will tell you, right?
Yeah.
Like, but those are the things that we sort of don't understand, or we don't. Not only don't we understand it, we're not interested in it. It's just like just he's got back pain. Just give him the pills for his pain. But back pain in this country, back pain is ridiculously common. So many unnecessary surgeries, and people just need to somehow do other kind of work. But again, part of the patients are part of the problem. It's not all the system. The patients are also, again, taught this thing, right? Go to the doctor. The doctor gives you, in pills or injections or surgery. It's an easier thing to do than, as I always say, the emotional work can be difficult, right? I mean, I think it takes a fair amount of courage to do it.
So tell me more about how the patients are part of the problem, because we spoke about this and how it's like taking responsibility for your health.
Yes. I mean, that's one of the things with when I sort of started with Gratefully Well, I had sort of the patient population kind of in mind, but then it evolved over time to where I said, patients have to be willing to take some degree of responsibility for their healthcare. Diabetes is a perfect example, right? So in diabetes, type 2 diabetes I'm talking about, yes, you do have to have the genetic predisposition to have diabetes. Okay. A lot of us have that. But in addition to that, you can modify the expression of those genes based on your lifestyle.
Yeah.
And so if you go in to see the doctor and you're 65 years old and you're overweight and you're very sedentary and maybe you smoke or whatever, and your sugar's up, right? They're going to say, oh, you've got this, your sugar's up, you've got diabetes, we're going to put you on these drugs, and you need to lose weight and walk. And that's all they say. And that's the visit, basically, right? And they don't really spend much time on anything more than that. But it's, even if you, and the part of the reason is because even if you do, like the drugs we have today for diabetes are very effective to help decrease and lower the sugar. That's important. Absolutely. But they're not going to cure your diabetes. They're not going to improve your diabetes. They're going to lower your sugar, right? But they're the underlying cause, which is insulin resistance. It's not really doing. The newer drugs have an effect on insulin resistance, but again, it's going to continue to be a problem that you need to take the drugs for. If you just go out and start, I'd like to say, just start living a more active life. I try to avoid the term exercise because a lot of people have a negative connotation when you think about exercise, right? They think about going to the gym, they think about getting on a treadmill, they think about running, they think about lifting weights. Those are all good things, but you don't have to start there for certain. You just have to be more active, and walking is a great activity. A lot of people say, well, I don't have time to walk. I'm too busy and I got 2 kids and I got this and whatever. And you say, okay, well, again, maybe go out and get some bikes with you and your kids, and you can go out and ride bike. That's activity.
Yeah.
You can do it as a family, right? And you're doing that together. And so talk about activity rather than exercise. And use the term like nutrition is supposed to diet. You say diet, people think about losing weight and paleo and keto and whatever. Again, it's more than that, right? It's a lifestyle. Like it's got to be sustainable. Keto, from my perspective, is not sustainable, right?
No.
As an example.
But useful.
But you got, what's that?
but useful in short term.
Oh yeah, very useful.
Yeah.
No, I just don't think it's something, again, but the problem again is, yeah, it's useful. You lose 20 or 30 or 50 pounds, but then you got to come off it at some point, and then you gain all that right back. So it's a lifestyle sort of thing. Knowing what to eat, knowing how to read a food label, knowing, getting rid of like ultra processed foods, which is like, in this country, ultra processed foods is like, it's convenient, it's easy, it tastes good. And so, very popular. But again, if you just teach people again, how, what is protein, what are carbohydrates, what are fat, what are good fats, what are bad fats, and, some simple sort of things. It's not a complicated sort of stuff. You teach them about activity, you teach them about nutrition, and to live a more active lifestyle. And there's a stress component to this as well. Learning from that emotional standpoint, how do you deal with the stresses of life?
Yeah.
Right?
Well, so even that though, like you can say to someone, yeah, well, you need to do nutrition and move and do all these things. And then if there's resistance to that though, like I'm working with a client right now who has used to be in the gym every single day, used to follow all of the diets, used to do all of these things. And there's almost trauma attached to doing all of those things because it was so intense.
Yeah.
So now it's like undoing the resistance to being able to eat the things that she needs to eat and to do movement. So the movement is literally swimming around in a pool and doing some aerial yoga, like just nothing that related to her old lifestyle, because we're still undoing the trauma that was created from too much.
Yeah, that can be a problem, especially for people. We see that sometimes in patients who are morbidly obese, who maybe even had gastric bypass surgery, things like that, to help lose the weight. But the same thing, they start to, they're just desperate to lose the weight. So they have the surgery, they start this incredibly intense. I had a patient who was a friend, and I think she would exercise like I think she went to the gym like 3 hours a day, just at the gym in addition to sort of other stuff, and she was just panicked about gaining the weight back. So there was this, and it was this trauma associated with everything that she had gone through, and she had lost a bunch of weight, but she was afraid that she would gain it all back. And so there was a lot of just post-traumatic stress.
Yeah. So what do you think the difference is then between like watching people on a journey when they believe they can get well and when they believe they can't?
So I think that's part of the art, right? So I always say medicine is, more art than it is anything else. And I think it's a matter of being able to understand the patient and communicate with the patient, and just like one of the things we fail at, I think, in the medical school system and in our healthcare system is we don't spend enough time teaching physicians how to communicate effectively with patients. And so physicians are horrible communicators. I mean, they will they'll see your test and they'll go, you had your echocardiogram, your ultrasound of your heart, and they're like, how does it look? Oh, it looks pretty good. Well, what do you mean pretty good? Like, what's wrong with it? All right. No, it's pretty good. I mean, it's good. It's good. Well, no, but you said pretty good like that. But meanwhile, it was normal. Like right. Doctors have this issue of saying like, you're or the heart, for instance, this is my favorite, like the heart goes through some changes as we get older, and the ultrasound can pick those changes up sometimes. And so they'll say, oh, it's normal for your age. What do you mean, like normal for my age? Well, it's does that mean it's like normal? Like, well, your heart changes, and we do very poor job of explaining complex things, but you can simplify them and make it so that people can understand this, but we do a very poor job. Okay,
so I've heard this before in clients that are like, well, I've been to the doctor and they've said, well, all of these issues are there, but you're just getting older, so don't worry about it.
Right. So well, look, to go back to the diabetes thing, okay? Like a lot of times, and I hear this all the time, your hemoglobin A1C is like in this pre-diabetic state, okay? Mm-hmm. So you're not diabetic, but you're headed toward it. And so that's the perfect time to say, if you do these things, be more active, and lose weight and look at what you're eating and how you're eating and do those things, you can reverse this. It's reversible.
Yeah.
Right. Like that's the perfect time to say that. But instead, doctors, nurse practitioners, they say this all the time. Oh, you're pre-diabetic, so you're headed toward diabetes, but it's not high enough to start drugs yet. But as soon as it gets over 6.5, it's 6.1 now. If it gets over 6.5, we'll have to start the drugs. Oh, okay.
Just keep
That's
doing what you're doing.
yeah. And so, and again, part of that, it's easier, right? You just like, you only have 10 minutes or whatever to see a patient, these days. And so that's part of it. It's just easier to sort of say that as opposed to saying, sort of educating them on the things that they need to do. But having said all that, again, trying to communicate with the patient, get them to understand some of these things so they're not scared. And again, help them see the changes they can make are doable sort of changes. Because again, if you tell, a 45-year-old woman who's got two, teenagers at home, she's working, she's keeping the house, she's got migraine headaches or whatever, she's overweight, and you tell her you need to start going, you need to start exercising, and she thinks I got to go to the gym, I got to start lifting weights, maybe I got to get a personal trainer. I don't have the money for that, I don't have the time for that. This is like, I can't do it. That's the first thing she's going to say. And so if you can say, hey, you don't have to go to the gym. You don't have to lift weights. Why don't you start get bikes and ride bikes with your kids as an example, right? Like she'd go, oh, that's exercise. Yeah, that's and that's like effective. That's incredibly effective. Go out and have do you like to run? No, I hate it. How do you like to walk? Oh, I love to walk, especially like through a park or whatever. That's effective. And so they need to understand those things there's misperceptions and such, but it's just a way again of communicating with them to a part where they can understand it, and they don't get scared or turned off or overwhelmed with now another thing they have to do.
It doesn't have to be all at once. It can be slow.
And it definitely doesn't have to be all at once. Definitely does not have to be all at once.
Yeah. So I would argue in that situation though, that, okay, well, if you're that unhealthy and that stressed and you're pre-diabetic and all of these things are going on, it's like, well, at which point have you put yourself first? Like there's something that's worth looking into, is like, why can't you actually take care of yourself before you take care of anyone else? And there's like often childhood traumas in that where they've had to be the parent really early.
Yeah, so that's a great point. I mean, I think, again, from an emotional sort of standpoint, that's why you have to look at this thing as, like the weight with the protection or whatever, right? And so there's a lot of resistance to that, and people need to understand to look at that and say, why is this? Where are we? Why aren't you taking care of yourself? You say, oh, well, I just don't have time, right? It's like, we all heard if you don't take care of yourself, you can't take care of anyone else, right? Like,
yeah.
And show that to people and stuff, but there's still part of it is sort of what I call the victim mindset, right? So it's easier to sort of play that victim role because we support victims, in our society, and so that's part of it as well. But at some point, if I get
better, I'll lose support.
Yeah, I'll lose that that sort of support, and so. So it can be tricky, right? But people need to at least look at that or understand it, or at least be told it. Then they can make a choice, at least, as I'm going to do this or not. No judgment. If you don't want to do it, you want to take the medicines and you're diabetic, take the medicines. If that works for you, fine. It's not going to cure your diabetes. There's consequences to that. But if you're not willing to take some responsibility for your own health care. And so I was saying gratefully, well, if you're not willing to take some degree of responsibility for your own healthcare, don't come to Gratefully Well because we got nothing for you. Again, it's not a judgmental thing. It's like you want to go to the doctor and take the medicines. That's fine. That's absolutely fine. This is not going to help.
I think you're right, inside of the system has created a bit of the problem though, because we've got this program in Australia called NDIS, and it's like, well, if you're sick enough, we'll just pay for all the things for you. And the government will pay for your healthcare, and you can go see the acupuncturist and the psychologist. And all. So there's like you were saying before, there's no incentive to not be that damaged anymore. And I've seen people almost create problems that weren't even there so they could get their piece of paper so they could get the help. And it's like we're supporting people to stay as low down as they possibly can.
Yeah, so here we call it disability insurance, right?
Yeah.
Security, and there's a ton of incentive, even though it's not much money. I guess it'll keep the lights on, right? And you don't have to go to work, but you convince yourself, right? And so back pain is the most common, and again, as people, yes, they have pain, but part of the pain, part of the reason, and maybe all the reason they have it is because they're not stretching, they're not, they're sitting all day long and all this kind of stuff. And so the more pain they have, the less they do, the less you do, the more you're going to get, tension in those muscles, the more contractures you're going to get and such. And if they go to stretch, it hurts. Right. And so it's so, I can't do that. And so it becomes this vicious cycle, but there's this this overlay, right, of, if I'm getting bad enough, even if I have to have surgery and stuff, I can end up on disability. It's not a conscious thing necessarily. It could be conscious, right? But it's like, then at least, I'll live off of the, the dole, as they say, and I won't have to work and I'll still be paid, but I'll have to live with this pain. But it's an interesting phenomenon, because who wants to live with pain?
Yeah.
Right. And, but yet we have programs like, a mindfulness-based stress reduction, as an example, was specifically set up to deal with these chronic back pain issues. And it's effective, but you got to do it.
Yeah.
Right.
Yeah. I've got a client that had, fell off all these injuries, broke his back, broke his arm, broke this, broke that, walks in just in so much pain, and never thought that he would be lifting weights or doing any of that stuff. And we've done 3 months of insanely deep emotional work. He really, really went there. And he walks in and he's like, oh, turns out that was nothing to do with any of the things that I thought it was. It was all emotional. And now he's squatting and deadlifting and running up mountains and doing all of these things. And even I was like, holy shit. I didn't even think that was possible. That's insane.
Yeah. Yeah. It's incredible when people get it in their head, right, that they want to get better. I don't know how else to say it.
Yeah.
Right. And they just know that they can, and they're willing to do the work, because whatever that guy's done, I can tell you, wasn't easy, right?
Yeah.
He was willing to, and you can't do it for him, right? And so he's got to go do it, whether it's both, in his case, it's probably physical and emotional, right? Yeah. Because even you got to do the emotional work, but then you're still left with this body, and you got to get reconditioned. You got to get reconditioned, and it's painful. Right. But you got to be willing to do that. And I would say the average person, at least in this country, is not.
Yeah. So talk to me about autoimmune and fibromyalgia from that sort of thing, because you had lupus. Is that right? Yeah? Tell me about that.
Yeah. So that, that's so a lot of as my practice evolved into this more, I'll call it holistically focused prevention, where I integrate what I like to call the non-physical dimensions of health into the evaluation and treatment of the patient. So the physical is already there. That's what we do in medical school. That's we evaluate and treat physical stuff, but we ignore what I like to call the non-physical dimensions, which are basically like mental health, emotional, behavioral health, cultural health, social health, spiritual health, right? These are the things that we don't know what to do with, so we just ignore them. I'm not saying you do them without addressing the physical. That's what we talked about. Address the physical, but in addition to that, right, especially if you don't find something physical, then look at these non-physical dimensions of health. And so if autoimmune disease is a great example, I think, because in autoimmune disease, you're basically making antibodies to yourself, to some part of your body. In rheumatoid arthritis, it's to the synovial membrane of the joints, right? In multiple sclerosis, it's to the myelin sheath of the nerve. In lupus, it's to your DNA, to your essence, basically, right? And so there's many autoimmune diseases, Crohn's disease, right, and ulcerative colitis, and all these. But anyway, and so again, if you look, we understand. So the immune system is the most incredible system that exists, and it's one of probably the most complex systems that exist. And we have an understanding of the neurotransmitter, neurohormonal kind of, of the process that goes on in the immune system. So if you take rheumatoid arthritis as an example, where you're making these antibodies to your synovial membrane, we know all of these things that are going on, the antibodies that are being made, the cytokines, the hormones, the neurotransmitters, all this stuff. We understand all of that. And so we then make drugs to stop that, right? To block the antibody, or to block the production of the neurotransmitter or the cytokine or whatever it is. But we never stop to say, why is this going on, right? Because the immune system is highly regulated, right? Because the reason it has to be so highly regulated is because it has to identify the difference between self and non-self, right? So self is all the parts of your body. But if something invades your body, right, like a virus or a bacteria or a fungus or whatever it is, or a cancer cell. So cancer cells are developed, it's a mutant cell. They are constantly being developed in the body all the time. But an active immune system notices that cell is not self. It's now different enough from the self, and it goes and attacks it and kills it. That's the way it's supposed to work. So you can actually think of cancer. I like to think of cancer as an immune deficiency because your immune system didn't actually pick up that cell, those mutant cells, and now it started to grow and multiply, right? But on the other hand, when something invades the body, you want the thing to attack it, right? You want to get rid of it. So it's very highly tuned, right? And so why would all of a sudden, because if your immune system's too low, you're going to die of infections. You're going to get, right? And that's what happens in AIDS, right? In HIV. On the other hand, if it's too active, right, then that's inflammation. So when your immune system is activated from whatever it is, a bacteria, whatever, that's inflammation, right? So when you start attacking yourself, that's an inflammatory process. We know that all the chronic diseases, all of them are inflammatory processes, right? But the immune system, when you're attacking yourself, like in lupus, where you're attacking your DNA or where you're attacking your myelin sheath. So the myelin sheath of a nerve, it's the coating, the insulation of a nerve. So if you look at your walls and you've got wires running through them, there's a wire that's of metal that's conducting electricity. But it's coated with a plastic, right, or with an insulation. If you didn't have that, the electricity wouldn't get from one end of the wire to the other end because it would all diffuse. So you need that insulation. So the nerves are exactly the same. They work electrically, and they're coated with this myelin sheath. And if you don't have that myelin sheath, the nerve doesn't function right. The electrical signal doesn't get from the brain or wherever it is to the spinal cord to the muscle. And so why would you start to make an antibody to your myelin sheath? Why would you make antibodies? Why would you attack your synovial membrane all of a sudden, right? And so it's sort of I think an interesting thing. But when you start to the people that I have seen who have developed these autoimmunes and then gotten cured, the medicines can be very helpful, and the medicines we have today to affect that inflammation can be very effective, but they're not curative. Again, because this is a problem if you're a pharmaceutical company, right, and you look at, hey, we're going to make a drug to treat rheumatoid arthritis and all this inflammation. And it's a very specific kind of drug, and a ton of people have rheumatoid arthritis. You stand to make a lot of money, but the pharmaceutical company is never going to say, but why is this going on?
Yeah.
Right. And so, because they don't care why it's going on, they just know that it is, and it's sort of effective. And so, but the doctors never sort of stop to ask that either. But when if you sit and you start to do,
I have a theory already.
Yeah, okay. I was going to say, you start to do this emotional kind of work, right? Then you will start to find all sorts of shit that kind of comes out. And a lot of these people, again, will play that victim role because it's like, I've got multiple sclerosis. It's not my fault, right? Because we always got this thing about blame. It's not a blame thing, right? It's like, but it's not my fault. I can't do this. I can't do that because I have multiple sclerosis. And you find that a lot of these patients have similar personalities and such. And so it's hard to do some of the emotional work because they have a personality that just doesn't lend itself to that. And as much as I love the emotional work and I think it's important and curative, not everyone has the personality sort of, that lends itself to that kind of work. Because as we said, it's difficult work to do, and you've got to be willing, you got to be open, you've got to be vulnerable, right? I mean, there's a lot to it. And so I think anyone with autoimmune disease, I think really needs to have some kind of emotional, work done as well.
So in hearing you say all of that is like, the body's not telling you the difference between what's its own and what is external. And so I would argue that, and and this makes sense from what I've seen, is that you're not telling the difference between yourself and other. And so then it's like, so because from what I understand, from what I've seen from the emotional perspective, it's like, well, I needed to be really angry to this other outside of me, but I can't tell the difference between outside of me and myself. So I'll just turn it back on myself. And now I'll just blame myself for all of the things subconsciously and internally, because I can't possibly be angry at them because I can't tell the difference between myself and other. And so now my body's attacking itself.
You've articulated pretty well. It's interesting because when I started, I was in my training, my residency, and I was doing a rheumatology rotation. So you see a ton of patients, rheumatoid arthritis, and you would see these people and they'd have these like joints that were just all swollen and red. And the attending physician would come in and they'd look at those joints. And this again, I was 25 years old, whatever. They would say things like, "Oh, that's an angry looking joint." Now, the interesting thing about that is years later, decades later, like I was reading this thing from Edgar Cayce, who was this sort of psychic that did this intuitive kind of, healing kind of stuff. And he said, I read this like separate. He said, rheumatoid arthritis is anger turned inward.
Yeah.
And like I read that and I was like, oh my God, like, use the same exact words. It was just interesting that the physicians would say, that's an angry looking joint. So it's again, like this stuff is sort of inherent. But yeah, I think that it's that stuff, right? And if you look at a lot of patients with rheumatoid arthritis, have what I call the nice guy syndrome, right?
Yeah.
So they're really sort of nice people. They're afraid to, rock the boat. They don't want any, so they go along. They never do what they want to do. They go along with everyone else. And they're, oh, he's such a nice guy. And look, he's got the poor guy. So he's got the horrible rheumatoid arthritis. He's like, so whatever. And again, I think it's like that unwillingness, right? I don't want to show my anger. So they just, turn it all in.
Turn it in themselves, yeah. I mean, the ones that I've had with autoimmune inside of the therapy, the rage is real. Like, worried the police are going to rock up while we're doing the screaming. It's like quite intense, the amount of rage. And you're walking around like, oh yeah, like life's good, and it's like you're pushing that back into your own cells.
Yeah, I mean, if you think about autoimmune disease, people die from autoimmune disease. I mean, people with multiple sclerosis and Crohn's and whatever. I mean, people get really debilitated and die from these diseases. So these are big deals, right? And so it's not surprising, right, that the emotion is just, it's heavy, it's big, it's and it takes a lot of courage. It's not an easy thing to do, and unfortunately, I think most people just don't have, I'll call it the personality. I don't know what else to call it, that sort of lends itself to that kind of work. But you have to be, like what the guy you were describing with all the pain and stuff, it takes a certain kind of personality. I don't know how else to put it.
So what I find is that it's kind of a tribe issue. Like, it's my social environment issue, because the amount of pain that it feels like to finally understand that, oh, in some way I've created this and I have to do something about it, and maybe I can get better. But your entire social environment is created around, well, if I'm suffering, then I get love and support. And I'm at this particular level, this is the social. So it's like, where will my social tribe be if I deal with this? Who's going to be left? And I've watched it happen. It's like they couldn't quite get there, because it was like, but who's going to be around me if I actually solve this?
Yeah. And Nick, you hit on what I think is a very important topic. And we don't talk about it at all. We don't really understand it, but it's exactly that, right? It's sort of like if I get better, right, am I going to lose this network, this support, or what have you, right? And so, the truth is, if you get better, things are going to change, and that's where I think it's scary, right? You're going to lose, what is going to happen to your tribe and your network and such, and so that's why I think only a small percentage of people can do it.
Yeah. So what do you think the answer is then to move from victim? Because you've gone from victimhood to self-sovereignty.
I was a super victim. I used to have. I needed to put a big S on my chest. And to this day, I still do that. but I recognize that, I'm aware of that, right? So my first thought is, it's funny because I've been doing this now for 30 years, and then my first reaction, maybe it's not thought, my first reaction is always victim kind of thought. And then I was sort of like, I start to chuckle because I was like, I can't believe I'm doing this for 20, 30 years, whatever it is. And that's still my first reaction. And so that's the first thing. The second thing is you have to realize that you have a choice in how you perceive a situation, an event. And that's one thing that we don't really talk about, that perception is a choice. And so now when I recognize that the first thing that really happens is I have a negative emotion. That's my signal that I've chosen, made that the victim choice. Okay. So whenever I feel a negative emotion, and so I don't even have to, I'm not great with identifying emotions, but you don't even have to identify. You just have to know a positive emotion or negative. You can identify those. And if it's a negative emotion, as soon as I see that I have a negative emotion, I know I chose the victim route, the victim path, as I like to call it, right? And then I have a choice. I say I can either continue on that path, but I'm doing it now willfully, like I'm choosing to do it. It's not being done, so it changes it significantly. But I can stay there. But why would I stay there? I can also choose to jump off that path and get on what I call the victor path, or the non-victim path. And the way I do that, there's many ways to do that. The way I do that is with gratitude. So gratitude it literally can be instantaneous. Like literally you just jump from one path to the other, where you just find, you're in your car, you left late, you had a meeting, you had to get to work to meet.
My morning.
You left late, and you hit traffic, right? And there's an accident, and it's like standstill traffic, right? Now you're pissed off, right? You're sort of just, God, I can't believe there's this traffic. I can't believe, it's raining. Why? There's an accident. People can't drive in the rain, be idiots or whatever. And you can do all that, right? And you can have that, and you can be justified in having that anger. You want to call it a just anger, whatever, right? But what's happening to you there when you make that choice, right? If you measured the physiology in your body, your heart rate would be up, your blood pressure would be up, your cortisol levels would be up, so your sugar would be up, right? All of these bad things are happening to you, and you can blame the traffic. Now, the truth is, if you thought about it enough, or if you talk to them, they left late, and they should have predicted that it was raining. There may, leave a few minutes earlier. It was an important meeting they had to get to, right? And so what they're really doing is they're mad at themselves.
Yeah.
They're projecting that out.
Yeah.
Onto the world, onto the traffic in this instant, right? And blaming the traffic or the drivers or whatever that is. And so if you can recognize that, but you can also just sit there and go, okay, I can't do anything about the traffic right now. It is what it is. It's stuck. It's going to start going. That, right? So that's sort of the first thing you have to say. And then not catastrophize, because what we do is tend to catastrophize. Now, this traffic has got it. It's the traffic that's a problem. I'm going to be late. I'm going to be late again. This is like the second or third time. Maybe I'm going to lose my job. Right? You can catastrophize it to make it sort of tons worse. So if you just say, hey, the traffic is what it is, right? It's 97 degrees outside, and I have air conditioning in my car. Thank God. Right? And then, hey, I've got a radio, and there's this great podcast that I can hear that Hannah's been putting on. I can listen to this podcast that I've been wanting to listen to, right? And so you can put on the podcast, and you can listen to the podcast. Take a few deep breaths, right? Just, again, we know that just taking 1 minute, literally 1 minute, right? And do a breathing, what I like to call breath work, right? That will lower, that will stimulate your vagus nerve, right, which will stimulate the parasympathetic nervous system, which is the calming part of the autonomic nervous system, and that will calm you down, right? And then you listen to your podcast, or you enjoy the air conditioning, or you just enjoy just the fact that I can just slow down for a minute, right? And then like weird things happen, like this traffic starts moving for some reason, like
So
right.
My statement in this would be everything. Like, can you get to a place of everything's happening for me, not to me?
Yeah. But that's a choice.
Yeah.
That's a choice, right? It's a perception. Hey, this is all being, this traffic, this, and all this stuff's being done to me. That's a choice, right? Or you could look at it and say, hey, this is happening, and it's going to give me an opportunity to do the breath work that I've been practicing or whatever. And it's going to, give me a chance to sort of calm down and do the work that I want to do. And so I appreciate the universe giving me this practice opportunity to do this. That's a choice though that you're making. Right.
And I think that choice, though, only happens when you actually start to go into this work. I mean, you can force it. And absolutely, like, mindset work is amazing. And you can force yourself into that place with choice, with choice, with choice, with choice. What if we actually manage to deal with the charge that came up in the first place that happens in the emotional body, because it's not from now, it's a projection from something else. What happened in the last week? What happened in the last months? What are you still holding on to from years ago? So when you get to the traffic, it's automatic because you've actually dealt with the somatic charge where you're like, this is for me.
I think that's what happens when you practice enough and you get to that place. So that for me, even though I'm going to pick that victim thing, that's sort of what comes up habitually or instantly, but it instantaneously changes to, oh, this is being done for me. And I take a breath and I'm good. I'm like, oh, is it? And I start to chuckle because I start to laugh because I was like, as I've been doing this for so long. And my first reaction, instantaneously, should I go right to the form? Yeah, maybe it'll get to the point where it's instant, but it's like already pretty like close to that, right? It's minutes to seconds sometimes.
Yeah. I mean, and I would also make the point of like, okay, well, if this is actually making you really angry, can you just get out the rage for a second and then come back to that? Because now you're not holding that in.
That's fine too.
Rather than it boiling
Right. But that's a choice as well, right? To sort of, get to the point. But ultimately, like from my standpoint, it's like you've got to get to you, right? Because it's you're beating yourself up, but you're projecting it out. And if you don't and that's why I always say not blame, but take responsibility for that.
Yeah.
Right. I think that's where you have to sort of start, right?
Yeah.
You're not willing to do that. And a lot of people are not willing to do it. It's because it's easier to blame the traffic.
Yeah. Or your partner or your dad or the dog or the boss or whatever it is in life, right?
And you build that up, right? Every time you get to the work and you tell the story over and over, and the story always gets embellished a little bit more, and oh my God, I can't believe that happened to you.
So tell me about the Gratefully Well.
So as the practice evolved into this, let's call it holistic sort of minded emotional work and such that added to the sort of physical, I wanted to figure out how can I, and it's wonderful. I love seeing the patients. It was very professionally satisfying and all that sort of stuff. But the business of medicine got to the point where I couldn't really stand it anymore and kind of got burned out. So I left and I went to the payer side of things. And I did that for a while, and I was at the FDA for a while. And so, but then I really missed the patient the patient contact. Mm-hmm. So I said, is there a way for me to do what I did one-on-one, face-to-face with patients? Is there a way for me to do that in a more group setting, right? In a virtual setting, a group setting, to where I could have more global impact as opposed to just a local impact. And so I started a company called Gratefully Well. Because gratitude is a big part of what I do, and the idea is I'm still working on how do I transform what I did one-on-one into this group setting. So I started, and just to let people know, so I started a newsletter called Gratefully Well, which is on Substack, and
amazing articles in there.
What's that?
Amazing articles in there.
You like those of her?
Yeah.
So
Yeah.
I'm trying to basically explain this kind of stuff.
Yeah.
And so that's been great. And then I wrote a book that's on Amazon that's called Holistic Health Pathways. And that was written specifically to show the evidence that exists for the physical and mental health benefits of gratitude. Right. So it was again, to say this is not all woo woo. There's actually some science that shows, like, we need science to show that gratitude is beneficial, but that's fine. We'll do that. And so that's what that book is about. I have another book that I just finished that I haven't made available yet. That's not going to be probably on Amazon. I'll probably be through their website. That is more on the techniques of gratitude. So I have specific technique that I use called the gratitude traceback method that really, because gratitude's important, but the quality of the gratitude is also important, not just the quantity.
Tell me about that.
So you've heard of gratitude journals, right? When I first started doing this, gratitude journals weren't even a thing. This is back in the late 90s, early 2000s, whatever. Now everyone gratitude, and you got to write down 3 things or 5 things or 10 things every single day. Well, think about it. If you're like, you're going to sleep and you go, oh shit, I forgot to do my gratitude journal. And you get up real fast and you write, I'm thankful for my family and I'm thankful for my job, whatever it is, right? And then you go,
lies.
Like, yeah, maybe that's effective, right? Maybe that's effective, right? But the quality of the gratitude, right, is also important. And so the way it actually came to me. One of the ways was again, this is, I think it was '05. I think it's 20 years ago, and it was a Friday night. I was driving home. And I realized I had to get some groceries, and it was late. It was like 8 or 9 o'clock at night. And so I stopped by the grocery store. Now, keep in mind, I love the grocery store. I love cooking. I love food. I love looking at food. I love the pots and the pans. I love thinking about how I'm going to cook. I love all the parts of it.
I can feel that gratitude.
Yeah. So I stopped at this store, and I was in a bad place. I was just like, I was tired. It was the end of the week. There was all this stuff going on. Money was an issue. All this kind of stuff was going on. But I walked in, and like, no one's in the grocery store Friday night except for me, right? Because it's like 9 o'clock at night, and like everyone's out partying or whatever. And it's just me and maybe a couple of like teenagers are going to get beer or something, And I go into the first section is always the produce section. And I go into the produce section and I literally get overwhelmed to the point where tears are in my eyes of like, all of a sudden I realized all of this produce, this wonderful, was all available to me. And I didn't have to like till the soil. I didn't have to plant the seeds. I didn't have to like take care of the land. I didn't have to watch it grow. I didn't have to harvest it and wait for it, and everything. All I had to do was take it and put it in my bag and pay for it. And it was all available to me. And I was overcome with gratitude until I got to the bread section. I got to the bread section. I was like, I started bawling. I mean, here there was like, 50 or 100 different kinds of rolls and breads and whole wheat and white and whatever. And I said, oh my God, I didn't have to like till the soil. I didn't have to plant the wheat. I didn't have to harvest the wheat. I didn't have to like separate the wheat from the chaff. I didn't have to mill the wheat into flour. I didn't have to take the flour and make the dough and wait for it to rise and bake it. Like someone did all that. And I started to realize, think about all of the resources that were necessary to get this loaf of bread to this grocery store for me to be able to buy, right? From the farmer, even like the farmer needed think of all the equipment that he needs to grow the wheat, right? The tractors and the stuff to till the soil and all the stuff he needs to do. And then he harvest the wheat. You got to transport that to wherever it's going to be milled, right? So you need trucks and you need tires and you need people who do that, right? And then someone's got to grow the food to feed the truck drivers who drove the trucks, And so, right,
You're in it.
Goes on until someone, then that. You make the flour, then that flour's got to get to some baker. The baker's got to figure out how to make all the bread. He makes all the bread. He's got to then package it. He's got to get it to a distribution center, right? Or to the grocery store so you can buy it. And I'm like, I'm complaining because the bread might be $7 or $8. And I'm like, I'm surprised it's not $100. If you think about everything that is necessary, right? And then I started thinking about that, about everything. You think about, you could easily complain about, oh shit, I got to do laundry. I hate doing laundry. I mean, you start to think, wait a minute, what was it like to do laundry 150 years ago?
Was that moment spontaneous for you, or were you practicing gratitude and then that built up to that?
I was already doing gratitude, and I was doing gratitude journal, and I had got into gratitude because I was looking for preventive wellness kind of stuff because I wasn't taught it in medical school, and I found there was a whole body of science, a whole body of literature on the physical and mental health benefits of gratitude as an example. And so I was already in it. I was already doing it myself. It was already overflowing into my practice. So yes, it was kind of spontaneous, but I was also already into that. But then I started to use, I call that the gratitude traceback method, because you take the fruit and trace it back to its roots, right? Or you take your washing machine, you're complaining about doing laundry, you think about everything, the technology, all the parts that are in, they all have to be manufactured. They're all manufactured by different people. Someone's got to, put those all together. They have to be done in a cost-effective way so that your washing machine doesn't cost $10,000 or whatever, right? And someone has to deliver those parts. Someone has to, again, so you need trucks, you need gasoline, you need tires, right? And so I call that the traceback method. And I think that when you do that, you just, instead of taking 3 or 5 or 10 things you're grateful for, you take one thing and you amplify that gratitude to the point where it's awe-inspiring. Call that the gratitude traceback method. So that's what the second book is about, how to do that in different situations where you can do that, right?
I mean, I'm feeling that in my body while you're saying all of that.
That's great. Yeah, it's awe-inspiring. I don't know how else to put it, right? And so where I do gratitude journal, I think that's great, and I'm not going to say it's not. But when again, if you're sitting in traffic, as an example, right? That example we were talking about, if you start to think about your car and the air conditioning and, the fact you can quickly take that anger that you had right toward the traffic, and that's why I say it works almost instantaneously to get you into a different emotional state. But it's a choice. You have to make that choice. Yeah. Right? And people are not willing to make that choice.
I have a little bit of argument with my partner all the time because he loves this stuff, loves the gratitude stuff, and always make the choice, make the choice, make the choice. And I have this argument of I hear you and I'm willing to get to that choice. But if there's an emotion arising, I want to know what that emotion is giving me as a gift. And, as an example, he couldn't come home last night because there was an accident on the main highway for him to get back home, to get on the plane because he's out at work. And here I am completely upset, that he can't get back, and it's, the middle of the week. Right. And he's saying to me, well, it's a choice. Be grateful that you get to wake up and breathe. People died on the highway. We get to breathe air. And I'm like, yeah, well, I can get there. But first there's an emotional response here. And I want to go to that because that's also a gift. And that emotional response is, well, I'm missing you and I want more connection. And there's a need and a desire here that I want to acknowledge, and allowing those emotions to be real, because there's some magic inside of that as well. And I think that can be a little bit bypassy sometimes when we keep putting the emotions to the side and go, I'll just be grateful, I'll just be grateful. And I'm not taking anything away from having the practice. And I think that's a really, really beautiful thing. And also acknowledging the gift in the emotions that are actually arising.
Well, men are from Mars and women are from Venus. and what you described, I think, is very much can be summed up that way. There is a difference. I completely agree with you, though. I think I told you a while back that I'm not very good at identifying my emotions. I didn't say it's because I'm a guy. That's what I wanted to say. But that's much more typical. Women are just much more able to identify their emotions and then process their emotions. But I totally agree with you. I think that, yes, that looking at that in a way, what is upsetting about that, to look at that but you can, the nice thing about having the gratitude is once you're done with that, right? Because what happens a lot for people is they'll stew with that, right? They'll just sit with that and they'll be just they don't know how to get out of it. Yeah. And the gratitude is just a tool. So that once you do that, once you're done with that processing, now you have a tool to get off of that and to get to turn that around instantly. So that's how I look at it.
And we can also do some alchemy, Julius.
Oh, no, totally. Yeah, absolutely. No.
We'll book some times in after.
All that work, I think those are tools to help you. Absolutely.
Yeah. What do you think the future of healthcare is if we actually manage to go down this road?
I'm not naturally optimistic. So I one of the things that I found out in doing a lot of this work is, and I thought I was this happy-go-lucky, optimistic sort of guy, and I found out that's not who I am. I'm this pessimistic. That's my sort of nature. And so I always sort of go there, but I don't stay there like I used to. And when I look around today compared to when I was a kid, so I'm 65 years old, right? So I was born in 60, so I grew up through the 60s and 70s. And when I look back at that time and I see where we are today, I think we are moving toward, there's a growing segment of our population that is working toward this, I don't know, let's call it emotional, spiritual kind of more holistic kind of viewpoint of life in general. And I see that growing. Now, is it just because that's the people I sort of hang out with? I don't know, but it just tends, like, you just take meditation as an example, right? TM, when they were talking about transcendental meditation back in I guess it was the 70s, it was a woo-woo kind of thing, whereas today it's much more common. That's even, talked about in corporate settings and stuff like that. And so these things are expanding. And I think I personally feel, and if you tell anyone I said this, I'll deny it.
Putting it on the internet, right?
I think women have played a big part in that. I actually think if corporate America is going to be saved, women are going to save it. Women are playing a much bigger role, and they're bringing in this feminine energy that we lacked in corporate America. So we were so unbalanced from a masculine energy sort of standpoint, and even back in the 70s or 80s, even women that came into the corporate America that got up to executive sort of levels, they were sort of, I always say, guys in skirts. They were just masculine.
They had to bring in the masculine energy to survive.
Absolutely. But today that's changing, and you're starting to see more of that feminine energy coming into society in general, and corporate America for sure. And I think if corporate America is going to be saved, I think women are going to play a big role.
I love that. I had a theory come up in my mind last week around that particular idea of maybe the women were collectively called to do all this deep work to really own this part of themselves and bring this to light. And the reason I think that happened that way is when the men, like even in romantic relationships, in business relationships, when a woman has done all of that and she's not projecting and doing all of this chaotic stuff and really owning it and taking responsibility for herself, men notice it. They notice the gap and then feel a really deep guilt at the way that they've shown up. And inside of that, it allows them to go, oh shit, I've got to do better, because that guilt feels so painful. And then of course we were supposed to lead that. Of course women were supposed to lead the emotional part of it. That's what we're capable of. And I think that, there's a lot of women out there that are kind of angry at the men for not getting there. And it's like, yeah, but we were just supposed to lead it first, give them some grace and show them the way. They will do it and get there if we can hold that space. It's kind of our job.
I think that's a good way to put it, and I agree with that. I think and I think that's happening. I think I'm seeing more and more of that, and so I am optimistic about it, and I think I see people more willing to take responsibility, for their healthcare than you saw like in the 70s. Let's just say, so it's moving in the right direction, I think, and will it accelerate fast enough? And I don't know. But I'm optimistic about it.
If you could change anything in the system first, what would you do?
I think the biggest thing that I would do, I guess there'd be two things. One is really start to train physicians in traditional medical school to communicate better with patients. And so we need to change a little bit about the way we screen for medical students, to acceptance into medical school. But there are increasing medical schools. Actually, now I think in the United States, at least, women outnumber the number of men in medical school. Yeah. So that's
interesting.
Yeah, that's very encouraging, I think, and love that. And so I think that's first. And then I think the second thing again is started to incorporate more of these non-physical dimensions of health into the evaluation and treatment of the patient. And I think that's important. The problem with all of that is, in the United States today compared to, let's say, 20 or 30 years ago, most physicians 20 or 30 years ago were self-employed, essentially. They were in practices whereas today, most of them have had their practices bought out and they are employed by companies, either healthcare systems or private equity companies. So they're kind of being told how to practice. And there is an increasing amount of professional dissatisfaction that is in that, and doctors are trying to get out of that. But right now, the business of medicine is so complex and so, I would just say, screwed up in the U.S. that it's really a challenge. And so, but if I had to pick, those would be the two things: teach physicians how to communicate and incorporate these non-physical dimensions of health into the evaluation and treatment of a patient.
Yeah, beautiful. And what can people do right now if they want to start taking responsibility and taking their healthcare into their own hands?
So I think it's important to start to look at this stuff, because now there's a ton of stuff available, right? The stuff that you're doing, it's just everywhere, right? And so I think there's a lot of things that the reason there's a lot is because not anyone works for everyone. And so you need to explore, but you have to be willing to first, as you said, start to take responsibility for your health, in that I'm important. If I don't take care of myself, right? We always use the airline thing, right? When you sit down and they tell you,
put your mask on.
Put your mask on first, because if you don't put your mask on, if you put your mask on, you can go up and down the aisles and put everyone else's mask on. But if you don't put your mask on first, you'll pass out and you won't treat anyone, right?
Yeah. What would you say to someone who wants to change, but they're feeling overwhelmed or powerless?
That's another great question. And so I think, again, you have to take this in small steps, right? And it's you don't have to do it all at once. But I would say 90% of it is the willingness. If you start to look at this and say, this is possible, there is a way. But it's hard because, again, you have to build up the courage, because you have to say, I'm going to take responsibility. I'm not a victim anymore.
Yeah.
Right. And to say that, as we talked about, right, there's a lot that goes on.
A lot.
Right. And there's a lot of fear about, again, losing your tribe, losing your network. What is going to happen if it's just easier to be the victim. And I think at least it appears, it's a perception it's easier. I don't think it's easier, but it can feel easier. And so you stay in that situation, you do that. And so it becomes particularly challenging.
Well, it's choose your hard then, right? Because that's hard. Being in pain's hard. Taking the other road is hard. It's choose your hard.
But the thing is, the emotional pain is more painful than the physical pain, right? And we know that from people who cut themselves and things like that, right? What is that? That's a distraction. It's a physical distraction that is less painful it's a distraction from the emotional pain, right? And so that becomes, it's hard. And so I sympathize, I empathize, I should say, because I've been there and I know what it's like, and it's not easy. Yeah. You have to be willing to start to look at it.
Yeah. Okay, so Gratefully Well then, what can people do to get in touch with you, to follow what you're doing? What's the plans for it all?
It keeps evolving. So as I say, this is still it's a little bit of a trial experiment. So the first thing is the newsletter. The newsletter is free. It's on substack.com. Called Gratefully Well. You can find it under my name, or probably under Gratefully Well as well.
I'll put some links in.
Yeah, thanks. And so most of the information will come. I'm probably going to use Substack as kind of my main kind of social media platform. Although there'll be posts on Instagram and Facebook. I'll have a Facebook group as well. But I like Substack. It's a little more professional. LinkedIn is maybe too professional, but I'll be sort of on LinkedIn as well. But anyway, so the Substack, the newsletter is free. And so that's for first thing. You can certainly look at the book. The second thing, is really the website is called gratefully-well.com. There's a 7-day gratitude challenge on there. I'm going to update that because it didn't really reflect the traceback method as much as I wanted when I first, that's from a year ago. And just didn't put that in there the way I wanted. So, but it'll be updated. But there's a 7-day gratitude challenge that you can sign up for, and then we'll be doing. I've done a couple master classes, so like a 90-minute master class introducing all this sort of stuff, and there'll be one of those probably once the holidays are over, probably once a month or so. And then I'll have like 6 to 8 week workshops that I'll be closed groups. So the masterclass will be just an open sort of thing. The Facebook group will probably be open, at least that part of it. But then these will be closed group of, I don't know what the numbers will be. Let's say 20 people or something like that. And we'll meet for 6 or 8 weeks and try. The challenge there again is, when a lot of this stuff is very sensitive sort of stuff and can be, difficult to do in a group setting. So how much are people going to be willing to share? How much they're willing to open up? But even if they don't open up, at least we'll go through techniques and things that they can do, because the hard part is always like you can teach the technique, right? But then someone comes back and they go, how you doing? You say, oh, they're doing terrible. I had this whatever happen. I go, oh, did you use whatever, the gratitude traceback method? Oh, well, no, like, how could I use it there? Like, they don't know how to implement the tools or how to use them at the time. So it's helpful if people are open to sharing those kind of experiences. And so part of that is going to be, how well do I facilitate the group? Like, does it feel like a safe enough place that people are willing to do that? So, it'll be a little bit of an experiment, but we'll see how that works out.
Yeah, might need to incorporate some one-on-one magic then there. Hey.
Yeah, so I was a little reluctant to do the one-on-one, but the truth is that the part I missed the most of all of it is the patient contact, and so the one-on-one patient contact, and so I just didn't want the problem with the one-on-one is it's hard to scale, right? And so I need to figure that out. But there'll be people eventually that will want one-on-one, and I'm not reluctant to do that. I'm happy to do that. I just don't want to have I just go back to my 15 or 20 patients a day or whatever, and I don't want.
You're getting close to retiring, huh?
Well, it's not so much yes, but it's not so much retiring. It's more sort of just that idea of it, maybe some post-traumatic stress of my own.
Yeah.
To that schedule and such. So yeah,
we won't dig into that one live on the podcast. All right. Well, that's amazing. I'll put links into the show notes for all of the things that you've got. That was a really amazing conversation, Julius. I really appreciate it. It's refreshing to have some real physicians in the world that are understanding this.
Well, I think when I left the FDA and I was sort of sitting there trying to decide what to do, and obviously I've been thinking about this for a long time, and it came down to the decision: do I just sort of become irrelevant and just ride off into the sunset, and do the retirement thing? And that was appealing, but I also felt that I had something to share. I don't like to think of it as teaching, because a lot of the stuff I came up with myself, and so I'm like, who am I to sort of be teaching it? But I'd like to share sort of the experience, and I think of it really as not replacing medicine, but as a piece that's missing in medicine. There's nothing to say that like, if you need surgery or need chemotherapy, you shouldn't do it. And that's not saying that at all. But if you do need surgery, or if you do need chemotherapy, you can do this in addition. In fact, that's one of the reasons that started. Kim, my wife, who had breast cancer, I was trying to do. I said, it's really important that she had this metastatic cancer, and I said it's really important that she practices gratitude. But I said, how do you do gratitude when you're getting chemotherapy and you're getting sicker and you lost all your hair and you feel terrible every week? You're getting sort of sicker and sicker. How do you keep that sort of grateful kind of perspective? And so I made this recording for her that I tried to get her to listen to every day, but at least listen to it like with headphones when she was getting the chemotherapy. And so it was very specific for her. It went through her doctor, her nurses, like the doctor appreciate that, he was knowledgeable and compassionate, knew how to, diagnose and use which drugs to use. The nurses, like how to start the IVs, how to infuse the drugs and things like that. The technology, the radiation therapy or the surgery, and to be grateful for all that sort of stuff. And to the point where she, the exercise, the meditation, whatever you want to call it, even said, looking at that chemotherapy and letting it in your body in a grateful way, not a positive way. This isn't positive psychology. It was more like, I'm grateful for that. Let it in my body to do the things that it sort of needs to do and leave all the other stuff alone. Now, she had metastatic cancer. She had a spot in her neck. She had 24 out of 24 positive lymph nodes. And that was cured. And she never lost her hair, which everyone says she was going to lose her hair. Because they give her a very aggressive regimen. They couldn't do surgery at first because it was already metastatic. And so they said, well, all we can do is give you chemotherapy, but that's not curative. But anyway, she was cured. And so again, I don't know what would have happened had she not done the graft.
How do you know? Yeah.
But the fact that like when she would go to the doctor, like she didn't have this dread that most people are going to have the chemotherapy. So at least it put her in a different frame of mind.
I would imagine that would have changed a lot.
Well, I agree with you, but again, I can't say what difference would have made. What
does she think?
N of one, we say, but yeah. So, but that's how that sort of started. Was really trying to do things like that.
What did she think about it? What was her take on the whole thing in that experience?
Well, she, it was. Again, it was hard for her to not play the victim role because it's much easier if she just, I'm getting chemotherapy, I'm sick, I can't do whatever and stuff. And she would have those days. And that's why this is not positive psychology. It's not like, it's kind of like back to what you were saying.
Yeah.
I fully feel that and embrace it and everything. Yeah. But at some point when you're done with that.
Yeah. Yeah. Yes.
Right.
Beautiful.
And then you can do that sort of stuff. And then that's what, basically that's where she found it to really be most helpful.
Beautiful. I love that.
Yeah.
Yeah. All right. Well, thank you very much.
I appreciate it. And it's an honor to be here. And thank you very much for the conversation. And you're a great interview. Thanks for the...
What a powerful conversation. Healing begins when we take responsibility for our inner world, not blame, not guilt, responsibility. Your beliefs matter, your emotional patterns matter, your mindset matters, and your willingness to shift out of victimhood into sovereignty is one of the greatest determinants of your long-term health. If this episode opened something inside you, if it challenged you, inspired you, or gave language to something you've been feeling, this is your sign to go deeper. You can connect with Julius and explore his work through the links in the show notes. And if you're ready to explore this work inside your own life, the emotional, physical, and nervous system layers of healing, you can connect with us at Recovery Jungle or also through the links in my Instagram bio. Because when you heal, you don't just change your own life, you change every person connected to you.